told us that he has that. And so we're thinking, is that tingling in his hands something we call Nintendo 90s? We play a lot of games, we have a bit of that numbness, some carpal tunnel. Could it be that? No clinical examination, which everything was negative. Is the twitching those normal twitching? On and off, you also have a cold shiver, a twitch. We don't know. So that's all he's giving us, and that's all we had. He had an episode. So he goes further, we dig. Because I told you, in epilepsy, history is the most important. EEGs, you catch about 30% of seizures. But without history, and without proper asking the right questions, you might not catch it if it's epilepsy, or if it's a seizure, it's a syncope. You need history. So we asked more questions. So this particular day, he said it was a little bit different. He said while he was playing on the phone in the school quietly, because you're not allowed to have your phone in school, so you put it under the desk and he's playing with it. He said he felt his hand grow bigger. So he could feel it growing. So he saw his hand getting bigger, and then he said his hand felt heavy as well. So he said he could actually feel that. Then the next thing he remembered, he was on the floor, everyone was around him. He was looking for his phone because he thought he dropped it or broke it. And he says that they brought him to hospital. He's fine now, nothing is wrong. And we did a full neurological examination. It's normal. CT scan was so normal. Bloods, we did an FBC, RP, LFT, looked normal. Vitals are stable. So they referred, is this a seizure? Is it a syncopal attack? Is this some kind of psychiatric conversion disorder, something we're not too familiar with? So this is the case we get. So what do you think? Since only 4 of you have the dilemma of whether it is a seizure or not, so I'm pretty sure the rest of you. So all feel it's a seizure. You're sure? So hand growing is normal, and so that's what we are going to find out. We're going to take a look at. So to start off, can we go back? There's no answer for this. You'll tell me at the end. So what we need to know when we see a patient with seizures, we need to know certain terms. If we don't know these terms, it's going to be a little bit hard to, when you read an article about seizure, when you look at things, you'd be a little bit lost. So let's just iron out the terms we need to know. The first term is called pre-ictal. Pre-ictal is a fancy way of saying what happens just before your seizure. You get some symptoms. Those symptoms are called pre-ictal symptoms. These symptoms can be minutes to hours, can even be days. It might be anxiety. They might say, I just don't feel so nice this past 2 days. Or I'm feeling a bit weird, sweating, undescribable sometimes. They can't really describe it in words. They may say butterflies in my stomach, and it goes away, but they know something is not right. It's not your normal day. That's usually a pre-ictal symptom. Then we have something called ictal. Ictal is during the event of a seizure. So when you say it's an ictal symptoms, it's happening when you're having your seizure. Pre-ictal, before your seizure. So an activity which occurs during that time is when you're having an active seizure. It's called an ictal event, ictal symptom. So it's a symptom happening there. It's an ictal sign if you see something. Okay. So an aura, this is important. So an aura is something they feel just a few minutes usually before a seizure happens. Very rarely, sometimes an aura doesn't turn into a seizure. But an aura is an early ictal phase. So when you have an aura, you're actually having an early seizure because it's an early ictal symptom. So an aura is different from pre-ictal because pre-ictal you're not even having a seizure yet. So when someone has an aura, it is most likely, and these auras can be sensory. They can have a bad taste in the mouth. They can even have the heart racing. They can have, I had a patient who had an aura which just is one hand had goose dimples, and that was his aura. So it's very, very different. I'll talk to you about auras a little bit more as we go along, but the gist of it is to identify, is it pre-ictal, ictal, is it an aura? And post-ictal is what happens after the seizure, when your seizure stops. So that's a post-ictal period. There are certain symptoms you need to look out. I'll tell you about them in a while. And then you need to know about, during a post-ictal event, there might still be an altered level of consciousness. So after the seizure, when it's all stopped, they may still be a bit unaware. They may answer one or two questions because they're still in the post-ictal phase. So you ask him, what's your name? He can answer, but he appears confused a little bit. Some of them may appear aggressive. So we call it an altered level of consciousness, post-ictal altered level of consciousness. So is it a post-ictal phase? When you have something post-ictal, it's very suggestive of a seizure. So loss of consciousness, some of them have cognitive impairment. They can't find the words. They can't speak for a while. Because it's a seizure maybe in the lower part of the frontal lobe or the middle temporal lobe. You can have that. So altered cognitive impairment after the event is very suggestive. So it's a post-ictal symptom as well. So physical symptoms, sometimes after your seizures, they may complain of fatigue, very tired. That is a very, very common post-ictal symptom. However, if you have a frontal lobe seizure, it's less common. With generalized seizures, very much common. So you look for these post-ictal symptoms in these patients who come in where you have a question, and you try and put it together, is it a seizure or not, based on it. Pre-ictal, post-ictal, does that fit in? Headaches after is also very common. They may have a slight headache, not like a migraine, a bit different. They may be nauseous. They may say, I was so thirsty after that. That's all physical post-ictal symptoms. Then there might be emotional or behavioral changes. They might say he was so aggressive for a while, then okay, but that's a post-ictal anxiety might be their fear. They said, I felt suddenly very frightened. Oh, suddenly after the event, they may be crying for a while. That might be, and it's still a post-ictal emotional behavioral change, it's called. So if it's there, very suggestive of a seizure. There might be some sensory disturbances, especially if it's in the parietal lobe. You might have some funny feelings in the hands. Amnesia is common. Autonomic changes are common. Autonomic means you might have your heart racing or heart might be slow right after the seizure. So look out for post-ictal symptoms when they come in. And all this you can only find from history because nobody really sees it. So identifying a seizure is a complex thing. It doesn't mean you need an EEG all the time. Because EEGs, remember, is only 30% accurate unless you're recording it overnight or 6 hours, which we don't do. So second term you need to know is secondary generalization. So most seizures that you will all see when it's in an older person is usually a focal seizure which goes into a secondary generalization. So what it means is it starts in one part of the brain and then it involves the other part and it goes generalized. So whenever you say it's a focal with secondary generalization, that's what it means. So you may have come in with tonic-clonic seizures, but it might have still been just started from one side. And you can only mostly pick it up from the EEGs. Sometimes from history and examination, it can suggest, which I'll tell you how it will suggest a focal seizure or not. Generalized seizures usually will happen in a younger age, genetic, because it's genetics and it'll start just suddenly. And also, it just doesn't start in a focal area. So that's another way to distinguish it, but not easy. So most patients who come in who has had like something which is suggestive of a generalized seizure, you don't know whether it's focal, you can just say it's an idiopathic generalized epilepsy. That's a very common diagnosis we tend to pull out from the hat and label it like that. And if you get more symptoms, you can do what Dr. Zul said and try and find out which one of those epileptic diagnoses he has from the current ILE 2017, which is a long list. No one is meant to memorize them. It's just, if you want to classify them further, you look through that. Okay, so another thing which you need to know is, which is called seizure semiology, the phenomena you see ictally and post-ictally sometimes. So, first thing is rhythmic movement during a seizure. So rhythmic twitching or jerking of specific body parts. So what I mean by this is when someone has a seizure, you're wondering, it always moves in a rhythm. That means it follows one, like a beat of the song. If you're clapping to a song, it always follows one beat. It won't go like this and then suddenly like that. That's two different rhythms. So when it's non-rhythmic, it's unlikely a seizure. When it follows a rhythm, it's more likely a seizure. So how it follows a rhythm, if they have a video, they play it for you, you look for rhythmic movements. Is it moving like in a rhythm, the same movement? That's rhythmic. Tonic is when all your antagonist and agonist muscles are all contracting together. It makes your hands stiff. So tonicity is very common. Clonic is when it maybe one of those antagonist or agonist relaxes, or both relaxes, it goes into a clonic phase. So tonic and then clonic. But remember, they go in a rhythmic fashion. So you can't have it like this and then suddenly like that and like that. It's always going, if it's like this, it's going to beat in a rhythmic fashion. Atonic, sometimes everything goes limp in some patients, and that's a bit dangerous because they just tend to fall. It's called drop attack. So if you have someone who says, suddenly I fainted, like he fainted and went limp and he had other symptoms, it may be an atonic seizure. Myoclonic is very brief jerks, like what Dr. Zul had said, and it's always involving just one muscle group, so the jerk of one muscle group. So that's myoclonic. If you call it clonic, you're not wrong. So it's just, if you want to be a bit anal about it, you go myoclonic. So automatism is the other thing. You see someone lip smacking. They do repetitive, purposeful movements. Some of them are like combing their hair, but it's very rhythmic. See, they keep doing that. There was a patient of mine, had a seizure in the car, and he had knocked something and he was having a seizure. When the cops came, he was doing this with both hands. That is very typical of temporal lobe seizures. This type of buttoning things, I will talk to, it's an automatism, but it's one of those common things you see in temporal lobe seizures. Lip smacking is another thing, where they'd be smacking their lips, sticking out their tongue, putting it back, but in a rhythmic manner. So if you can pick it up and it looks rhythmic, it's most likely automatism, it's most likely a seizure. That diagnosis is going to fit. Then there's versive movements. Versive movements just simply means a head moving to one side. And then in the older days, they say your eyes always looks at the area of the stroke, but these days they say no, it's not very specific. So it can be, even if your stroke is on your left side, you might look to the right first and all, because there is always some rhythmic movements in those other body parts. But in general, your eyes look to the side of the stroke and your head turns to the opposite side. That's the general thing. If you want to describe a stroke and you think it's a focal thing, you can sort of do that. Then there's something called sensory phenomena. So in the parietal lobe of the brain, if it's a focal seizure arising from there, you get a lot of these sensory changes. Some of it may be tingling in the hands. Some of it you might feel the limb actually changing, becoming dysmorphic, becoming heavier, like our patient who had a parietal lobe seizure in the first question. It may change, and he will give you, and it would have. So when he said I had some twitching in the hand, our job was to find out, is that twitching rhythmic or not? If it is, it's going to suggest a seizure. We didn't do that, but that's what you should be doing. So sometimes you'll have, when I say sensory phenomena, all the senses, touch, smell, you might smell something, you might taste something in the mouth just before the seizure, just after, postictally you can have these sensory phenomena. Cognitive phenomena, you may have altered awareness. Some of them behave very oddly just before the seizure or during the ictal phase. So especially in frontal lobe seizures, they can do that. I'll go a little bit more in detail on frontal lobe in a while. Emotional phenomena are the feeling of anxiety, tension, anger, joy, crying, laughing. You can have all that, and that can be an ictal or post-ictal symptom. So you see, I'm using those terms. So during a seizure or after a seizure. That's what people will be doing. If you read them, it's an ictal symptom and all that. So I told you those terms are quite important, because we'll be talking in terms after this. Okay. So up to this point, anyone wants to raise their hand and ask anything? No, no, no. All right. So, oh yeah, we still have some more autonomic. So sometimes When the seizure is a bit advanced, or it's a bit more stronger, especially in temporal lobes or generalized, you can get autonomic phenomena where your heart rate shoots up. Problem is sometimes these autonomic symptoms, your heart rate tends to drop. And that is dangerous. So when we do EEG, sometimes we put the heart rate monitor there. If it drops to very dangerous levels, they need a pacemaker. They become very complex seizures. Sometimes there's heavy breathing before it. Some patients will tell you, my whole hand changed color, my whole leg changed color, so skin colors changing, one part of the body sweating. Those are autonomic phenomena suggestive of seizures. Psychic phenomena are also there. People like to talk about deja vu. They say, I felt I was here before, then I had the seizure. That's a deja vu. Jamais vu is where you don't recognize where you are. So sometimes they say, I don't know where I was, and suddenly I woke up in a hospital. It just might be that. So dig deep, and you might be able to identify them. So we will come to the second case, where we will start this like this. And you can see he's now focused on one side, just looking a fixed gaze. It might be a pre-ictal or an aura. We're not too sure, but it's either. You're not wrong if you say that. So it's got a pre-ictal state. So now you can see he's starting to get some tonicity in the mouth. It's just becoming hard, and now the hands, and you see the legs are becoming tonic. Tonic, no clonic yet, because there's no rhythm. If someone had seen him, they've come, put him left lateral. And you can see now there's a bit of clonic movements, which is some rhythm, it's following a rhythm. So that is a generalized seizure, or is it? So let's ask the question. Is there a question here? Question 2. So is it a generalized seizure? Is it not a seizure? Or not sure? So everybody knows it's that. Okay, so let's go back to the... So that's an easy one, so don't worry. It gets a little bit harder after this. Okay, so I put this here because I thought I would talk a little bit about these, because some of the particular symptoms come from certain lobes. In the frontal lobe especially, it might start on one hand and then the whole limb and then the leg. So it like progresses into different parts on the same side. That is called a Jacksonian march. Why it's called that? Because the person who discovered it saw his wife having a seizure and he realized, oh, it's following a pattern, so it became Jacksonian march. A lot of people like to talk about it because it's seen very commonly in a frontal lobe seizure. Tingling feelings in the hands, very common frontal lobe symptoms. The head turning usually to one side is very common in frontal lobes. In parietal lobe, so if you see just between the blue and the red part of your brain in this diagram is your central sulcus. That divides your frontal and your parietal lobe. So whatever touches the parietal lobe is your somatosensory cortex. So all your sensations are there. So you'll get a lot of those sensory tingling, numbness, heaviness, even some amount of proprioception is in your parietal lobe. So those are parietal lobe symptoms. So like that boy he felt his hand heavy and he felt it growing. That's a parietal lobe symptom. So occipital lobes, not so common, but sometimes you get it. You get all your eye symptoms, flashes, floaters, scotomas, reduced visual field, curtain closing. So most of that can be an occipital lobe seizures if it's followed by other pre-ictal phenomena which we were talking about earlier. Temporal lobe, the very common thing they say is the deja vus and jamais vus are very common. Lip smacking is very common. And an altered behavior during the seizure, they may change, get aggressive or get emotional, very typical in temporal lobe seizures. So I just put that there because these are typical things you see. And let's see this case now. Now let's look at her. Okay, so this lady was called to us. She's pregnant, she just delivered, and then they noticed she had these funny movements in the ward. And they called us and said, is this a seizure or not? Doesn't look like a seizure. We don't know whether she's psychiatric. Husband says a little bit depressed after the pregnancy. We're not so sure. He's never seen this before, according to us when we spoke to the husband. And so we came and we looked at it, and this is the first video. Let me show you. Yeah, where am I? We'll start like that.
Lawati. 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 Okay tak?
Okay.
So she recovered quite fast. I don't really, to me, I can't really tell if there's any rhythmicity because it's going all over the place. She's like trashing her limbs. So let's see again from a different angle, because as this stops, it will start again after a while. And I told you about post-ictal tiredness, drowsiness, hardly there for her. So let's see again. It just happened again within that few minutes when we were there. Happened again, and this is how it is. You can see some trashing on the legs. Might be rhythmic, that head combing thing, but then it stops. And she's able to answer a question. So they were shocked. The ONG people said, is this a seizure? What is it? So I don't have my post-ictal, which I told you a lot of them get this post-ictal tiredness that will be like a gold mine, yeah, seizure. But this one she could add, no confusion, not so much. But she had this violent thrusting. So what is our question? Is this a seizure? Is this not? Oh, not sure. Her EEGs were normal. Because they said, can you do EEG? He said, yeah, I can. HKL, we have everything. So we did one. Normal, is it? Now what is it? Is it? We have yes, no, not sure. So would you treat? So I told you he and some of the semiology. So let's see. That in frontal lobe seizures, you might not have any post-ictal drowsiness. That's the only problem. Frontal lobe seizures, you'll have all this trashing of the limbs. Sometimes they are aware of it, sometimes they are not. Very prominent features. Sometimes they're even bicycling. Sometimes there's a fencing posture you would see just before the seizure. We had a 12-year-old kid. His seizures was late at night. Frontal lobe seizures tend to happen when you're drowsy, when you're sleeping. He got up, started running around the house, screaming, throwing, opening the fridge, closing the fridge like that. And then sometimes he would just drop to the floor. So parents thought maybe he can't remember he's doing that. Parents filmed it, thought maybe he's possessed or something, or maybe he's sleepwalking. But that's a frontal lobe seizure. It happens, and it's very erratic, and and the thrusting of the hands is very common, like this lady, and they recover very fast. And it's clustering. Clustering means it stops after a while. It happens again, stops, happens again. Very common in a frontal lobe seizure. Not sometimes very bizarre, like the running and the cycling, like that small boy, and the awareness is preserved. So this was a typical frontal lobe seizure. Not easy, not commonly it presents with it. A lot of them go into a secondary generalization and they have all those post-ictal symptoms. But this is just one which I wanted to show you, and which had clustering. It had the thrusting of the hands. It was occurring usually during her sleep, without any post-ictal drowsiness. She's very alert. She could answer immediately. So that is, there was some rapid generalization, because I told you a seizure on one side is it is focal, but she was having both hands thrusting, so it went into secondary generalization very fast. There was minimal or absent post-ictal. Some head and eye deviation, if you actually look very carefully. It's there with her, but it's not easy to pick up. Autonomic symptoms might be there if you put on a ECG or a cardiac monitor. Some emotion manifestations may be there. Most of them have some auras before the seizure. So if you dig, you might find a little bit. So now let's see this one. This was a young boy. He's about 13 years old. Father says he's very naughty, doesn't want to go to school. And he wanted, he does a lot of naughty things, throws rocks at the neighbor's house and all that, and they reprimanded him, and he started having this behavior. And they don't know whether he's faking it, or he's not, or is it a seizure. So they're a bit worried. They brought him to hospital, and this is what he was. It happened with us. So that's...
नाम बताओ अपना नाम बताओ नाम क्या है
That's the father calling him.
नाम बताओ नाम क्या है तुम्हारा
Sometimes he's listening, sometimes
नाम
he's
क्या है
not.
नाम बताओ
That's what the father says. That's all we got. We couldn't really see a post-ictal drowsiness or fatigue. He was just not very talkative and he was not doing that. Obeyed commands, vital, stable, city brain normal. Seizure or not seizure? Seizure. Why is he barking then? Seizure, everybody thinks it's a seizure. Okay, so that was a temporal lobe seizure. You can see the lip smacking, which is very rhythmic. What you heard was barking during the seizure. So it's just simply called ictal bark, because it's happening during the seizure. When you see this, it happens in your mesial frontal lobe and sometimes in some temporal lobes. So people in neurology get a bit excited, they record these, because very, very hard to find them. So this guy had a temporal lobe seizure because of the more automatism and stuff. But ictal barking was what you saw. And then if you watch carefully, there was a part where he took a big yawn. Because sometimes when we need more oxygen to our brains, we yawn and we yawn big. And that's what happens because there's some activity going in there. The brain is telling us we need some oxygen. He goes, there's a big yawn there. And there was impaired awareness usually is there. Sometimes there will be some staring and a fixed gaze. You notice he had a fixed gaze. So in temporal lobe seizures, even if he has impaired awareness, he may seem to have looked at you for a little while, but he's not responding. So even though the father says, yeah, he's just looking and he's not, but he was not responding. He still had impaired awareness. It may have looked like that. So temporal lobe seizures have this staring effect sometimes. Speech disturbances in his case was a bit of barking. Sometimes they're aphasic, dysphasic, they say they can't talk. Sometimes there are verbal automatism. You find them repeating the same word over and over. Yes, 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 yes. That's verbal automatism. So comes from the temporal lobe. Head deviation, eye deviation can be there like the frontal lobe. Dystonic posturing, the head can go up, the hands can just have a posturing. Dystonic means it just becomes like hard and there's a certain, it assumes a posture. So it can be hard like this, it can be hard like that, it can be hard like this. They are all dystonic posturing. Autonomic signs, very, very common with temporal lobe. So if you ask history, they may give you history like, yeah, I was pale on one side, I was flushed. My mom said my right ear was very red. There was some changes in heartbeats, can be very common, either goes up or down during in the ictal or pre-ictal phase. Incontinence, less common, but it also happens. If you are there and it's happening and you see pupillary dilatation, very suggestive, but it's a bit hard to see unless it's light-colored eyes. And what people like to talk about is something called gallostatic seizures, where they just laugh. You can, if you write gallostatic seizures in YouTube, you'll probably see a lot of those kids having it, because pediatric neurologists like that. They would see, suddenly they'll be laughing, and it stops. And there will be some other symptoms to follow, and you'll realize it is a seizure because they have some other ictal symptom. If it's just crying and it stops, they have a nice name for that. Dacrystic seizures, that's what it's called. So that those are very common temporal lobe seizures. Lip smacking also very common, seen in temporal lobe. And then we come to the fifth case. Fifth case is this lady, husband left her. She's now living with her parents and stopped working. Was a very brilliant accountant, but now not working at all. And she said she can't work because there's some movements in the eyes and she's getting twitching, and there's some post-ictal symptoms. She's reporting very drowsy. She's very tired all the time, even after these events, and sometimes these events keep occurring. So parents don't know whether it's a seizure. Parents don't know whether it's something in the brain. They brought her in, and a friend of mine is seeing her, and he's trying to elicit some signs to see whether it's a seizure, see whether you can pick up the signs he's eliciting, and is it a seizure? So let's have a look.
Look at the eyes. Yep. Just try to relax and see. Maybe you can get better with relax it. Just try to relax. Breathe in and out. In, out slowly.
So he's trying to see if she's following commands. So a lot of times, impaired seizures don't. Aware seizures maybe.
Down. All right. Okay, just breathe in and out slowly. Okay. In, out slowly. You can stop breathing. In, out slowly. Okay.
And that's, so we end here. No. Okay. So if you look at this one, so this is when he's observing her from far. You can see twitching on the hands, left hand and right leg. And these twitching, the family says, is always, it's been there, it's new. EEG was normal because, 30% we can pick up, 70% we can't.
Break ED. Look at the eyes. Yep. You break ED.
So okay. So what is it? Where's our question? Seizure, not seizure, unsure again. This we have the patient right in front of you. All the results are there. CT brain normal, bloods normal. EEG, we even told you, done in a private center, normal. But these are the things you observed. There was some movement in the right leg, left hand, which we saw. The eye had those funny movements. I'm not sure whether they're rhythmic or not. Could you all tell? Seizure, not seizure? Looks like nobody wants to answer this one. No? Let's leave it as a mystery then. No? No? Anyone? Hands for seizure? Hands up. So we have a few seizure. Not seizures? Only one. One person says not seizure. So, my question is, if you thought it was a seizure, or if it is a seizure, were the movements rhythmic, following a rhythm? Think about it. Was it, I told you, secondary generalization where everything goes? So remember, when I say secondary generalization, all your limbs are involved. You don't have one right hand, one left leg, because that's not secondary generalization. There's two focal seizures. You don't get that. You don't get two at once. So she had a right hand, right leg, left leg, so that already is telling me it might not be a seizure. She had some depression there, so it might not be a seizure. So what was it? It's what we call it, what we will see a lot nowadays, psychogenic non-epileptic seizures, PNES. So there was a consensus in 2018 in ILAE, the International League of Epilepsy. They said they don't want to call this pseudo-seizures because it's a very taboo word, very harsh, so they took it off. But it's the same thing. And then it was called non-epileptic attack disorders. Then people didn't really like that. A lot of people call this functional seizures or dissociative seizures in America, but the general term now is psychogenic non-epileptic seizures. That's what we call them. They're all the same thing. It resembles epileptic seizures. It can mimic an epileptic seizure sometimes. And there's no abnormal brain activity seen when you do an EEG. There's usually about 80% of time some psychological trigger is there. Anything which is psychological, so history is very important here. Involuntary, so the individuals are not consciously faking the symptoms. This is very important because they don't know, the mind is so strong, they feel the symptoms is real and whatever which is happening is real to them. It might be silly and it might look fake to you, but to them it is very real. So that's why they call it psychogenic non-epileptic seizures, and they don't like the pseudo-seizure terms because they're not faking it. The symptoms are real. But what you will see, which is very common, is non-rhythmic movements. And you tend to see pelvic thrusting, where your pelvis moves like Elvis. So it thrusts. The reason they do that is when you want to move your leg, you thrust your pelvis, it's a bit easier, less energy when you use your girdle muscles to move. So sometimes they say pelvic thrusting is very pathognomic of PNES. So look out for that. She didn't have it, but that's one of it. And it's very common. When a patient does not respond to epileptic medications, 20 to 30% of the time it's PNES. So that's a big clue because these medicines work well and it's been there for years. So it's not like, oh, it doesn't work. 5, 10 medicines, 3 medicines doesn't work. You should start suspecting when they're not responding. And with that, we will end before she throws the bell at me. With this, we'll have this case first before the last case, and you tell me what you think. So this girl, on and off, she has a very blank-looking stare. The ED physician called us and said it looks like an absent seizure. Just blank stares. Didn't have those blinking, which what Dr. Zul showed, but blank stares. Someone elicited a very strong pain stimulus. She did not move. And she was just a blank stare, and it happens for a few hours, half an hour. Absent seizures can happen for 2 to 3 hours, theoretically. So is it an absent seizure is what they were asking us when we saw her. So let's have a look.
Cuba panggil dia, call dia. Saya tengah ambil video.
Veronica.
Lagi?
Veronica.
So she's not responding. We pushed her to the side like this. Okay. A bit of twitching on the left hand.
Veronica.
But now watch the face.
Teresa?
That's the blank stare. She just happens. With pain, she's just staring like that. Someone gave her a good stimulus here in the ED and here, which you're not supposed to do, but they did it. She was just like that. She's not Mike Tyson, so we don't think her pain threshold is that high, but could it be? Functional PNES or seizure? Question. Not sure. Not seizure. Oh, seizure. One person thinks it's a seizure. Everyone thinks it's not a seizure. Not an absence seizure. Okay, let's go back to the slides. So, what we usually do to find out is called a drop test. Don't need to elicit pain, because some of them, they don't respond to pain like her. So a drop test is where I take the hand, I try to drop it on top of your head, and you will naturally deflect. So we know you're aware, you're not unaware. And this is what we did in a drop test. Someone is doing it now.
Okay.
So he tries to drop, and she goes. She avoids it. Not floppy, so we know it is functional. And it's not an absence. So you can do that with some seizures. It can suggest. So that's called a drop test. And with this, is it a bit better? Everyone can get more or less diagnosed a seizure from here. Can. So rhythmic, post-ictal drowsiness. And who feels they can diagnose a seizure a little bit better? Anyone? Only 2 people. My God. Okay. Anyone brave enough to come up to describe what they're seeing in the last video and tell us seizure or not seizure? This person filmed by his wife, and he's having these movements at night. Anyone wants to try? No. We will call anyone? Anyone brief? Don't worry. If you make a mistake, only I will laugh. No. Nobody? We call Dr. Zul then. Come. So can someone just pass Dr. Zul a mic, if it's possible, or you can share my mic. You can borrow her mic, and you... there's a mic there. Okay. Anything... Okay, just have a look at the seizure and you see what anything you see, yeah? Not now. Okay, so it starts. The patient is apparently asleep at this time. They're recording him. Okay, so you can see something in the legs, something in the hands. Starts. This is apparently the ictal event. So remember, you're looking out for rhythmicity or whatever we talked about. It's not easy, but then it stops for a while. And then it starts again. And after a while it stops. Okay, yeah. Who thinks it's a seizure? Hands up. Oh, seizure? I have one group. Functional? Functional? Hands up. 1, 2, 3. So let's ask our expert, Dr. Zhu. What did you observe with this?
There is a pelvic thrusting, pelvic thrust. So this is a typical of psychogenic non-epileptic seizure, PNES. So
that you can see there was, yeah, he's right, there was some pelvic thrusting. You can see that there was suddenly fast, suddenly slow, that's non-rhythmic. And no seizure will stop and then suddenly start again unless it's a continuous status. So it is a very PNES, but not an easy seizure to pick up. And till today, nobody can 100% say something is psychogenic without doing all those tests. And there's no one easy answer, just things that suggest. So with that, I will end. Thank you.
Thank you so much, Dr. Mahavishnu, for the very, very fascinating and engaging session. Everyone, don't go around diagnosing seizures in everyone else you see, okay? Okay. Can I allow one question because time is jealous of us? So, most patients in the video were only observed by paramedics without intervention. How long should we wait before we're giving anti-seizure meds?
In the video were only observed by paramedics without intervention. How long we wait before giving anti-seizure medication? I assume you asked how long we wait is during the event. We need to abort the seizure as soon as possible when it's happening. Because like Atika said, there's a T1 and a T2 phase. Your T1 is when you use all your short-acting drugs, your benzos, your midazolam or something to abort the seizure. Because once it hits the T2 phase, there's going to be neuronal damage. So you want to abort it as quickly as possible. Then you start the longer actings like your phenytoin, Capra and all that. So if it's an active seizure which is happening, please stop it immediately as soon as you can. If it's something which has come in and is not seizing right in front of you, you have to start the medication as soon as you can if you think it is a seizure. If you think it is a provoked seizure, that means it's not sleeping, hyponatremia, you may wait. So because they say sometimes for seizures you don't treat. So that's, I hope that's the answer. Okay, let's see. The second one is, can you share your personal experience of treating patients with ketogenic, ketogenic diet or neurostimulations? If have time, share. Thank you. Okay, so if you go to any epilepsy conference now, they will all employ ketogenic diet because they say it reduces this frequency of seizures to about 30%. So you have someone who has seizures on a low-dose medication, a ketone diet does help, but it helps as well as cannabis, CBD oil also helps, but all that helps a little bit. But intermittent fasting, which produces ketone bodies, does not. So if someone in TikTok says it helps, it doesn't. So that hasn't been established. But ketone diets, yes, it helps a lot. So you have someone who is not on an optimum dose of medication, like what Zul gave a rough idea. Lamotrigine, you should hit about 100 BD. Capra, you should be about 1000 BD to know you're around the optimum dose. Epilim about 400 BD. If you're below that optimum dose and you're a bit worried, you may still see ketone diets